in the morning presentation, when Mr. Mehta from Ahmedabad talked about the mandate of the RIO, he mentioned RIO is the role model and then accountable for the eye care for the state or for the region. So it obviously gives an impression that RIO provides what is required to take care of the eye care of the people in that state. And then today you heard a number of presentations of either for cataract or for specialty or using technology to reach out to the villages and all that. So just reflecting on it, how practically is it for you to get into that depth of outreach?
Outreach to the community.
To the community. I know that you have too many patients to start with.
Yeah, the analysis of the statistics from the different RIOs have shown that some have very high volume of patients.
And you are one of those.
I think we top the list, but ratio of doctors and the cataract surgeries, we are towards the bottom. That is many reasons for that. For cataract surgery, not many patients are coming to our institution from the periphery, because the periphery there are a lot of ophthalmologists who are doing cataract surgery, and there are many hospitals, even private hospitals from Kerala, from Tamil Nadu, coming and conducting camps and taking away the patients for surgery. We are also conducting camps, but we don't have a vehicle to bring the patients to our hospital. So we go there, check, and ask them to come, ask the voluntary organizations for organizing the camps to bring them, but many a times it is not happening. The patients we get are mostly the referral patients, diabetic, glaucoma and all that, and majority of them are just coming for trial of glasses, for checking glasses. The reason is, in the periphery, there are doctors who are doing the cataract surgery, but many of the Taluk hospitals don't have an IOP every day. Okay. So the patients are not sure whether if they go to there, they will have they can see the ophthalmologist there, because there will be only a single ophthalmologist who is taking the other duties. They will be on off or they will be having a holiday. So the absence of a regular OPD in the peripheral hospitals is the reason we are having a high volume OPD.
Okay, so I think you have a very high load, but what you're implying is that a lot of it is very simple kinds like glasses and things like that. So if they could be stemmed at that level, it would help. No, yeah. So and plus you raised the issue of resources, people and vehicle and things like that, as being the barriers. So given that, I think Mr. Chakrapani mentioned about this excellent computer. What is their unit called as? Akshaya. Akshaya. In Kerala, the Akshaya network of computer centers. So do you see any scope of integrating them into your work?
They are already doing the registration for the health insurance scheme in Kerala. They are doing the renewal of the health insurance scheme online. They are also doing the registration for Rashtriya Bima Yojana. These are the programs which are already being handled at the Akshaya Center.
But given that she is giving the exact same problem as Tripura had, where they were seeing too many people with very simple problems, and in your setup also your system is clogged by people wanting glasses or something simple.
But
so can that be?
Akshaya Center is not contributing much to eye care as such. My experience in Kerala, I will say, we have a mobile teleophthalmology unit that is going to 5 peripheral centers on a fixed date every month. Unfortunately, these people in the periphery are not utilizing that service to full extent.
Sir, as far as I see the status of RIO in states, because about 5 years back our department was upgraded to RIO. So what I see, the main aim was to provide tertiary eye care services in the state to upgrade, and that's why 4 units were, specialty units were created, which were not in the department, all were general ophthalmologists. So from this meeting and a meeting which we had in Nirman Bhavan, what could I get? That each RIO should have a special community ophthalmology wing. And the state program officer, they should work in collaboration with that wing. Only then we can make best use of the community services. Because in Haryana, in almost every primary health center, we have a primary ophthalmic assistant working for that. And at every district level, we have 2 to 3 eye specialists. So that way, if we have a community ophthalmology wing, we can further develop the outreach program in a better way, and we can conduct camps not only for cataract, but for diabetic screening and glaucoma and all others. That will be more useful if we have a wing community ophthalmology. Along with the state program officer, they should be answerable to that. Presently, we don't have any communication with the state program officer. They are directly under the state director health services, and they have no communication at all with the RIO. Rather, we send our statistics to them. They are not. This is what I want.
So can some SPOs respond to this about, is that specific to Haryana or is it, yes sir?
In Tamil Nadu, we have association of SPO along with the community ophthalmologist who is supposed to be seen as a surgeon, and he's got some assistants also. He keeps sending the doctors for screening in and around Chennai district, and keeps collecting cases and buying and operating, and they are giving the statistics to the state statistics, and it's working very well, sir. Another thing I just wanted to ask Kerala SPO, is it the correct figure that you have given us 2,70,000 the OP attendance in Kerala? Generally, the Keralites have a tendency to go to a private practitioner rather than coming to the government. Number two, the overall population is definitely much less than Tamil Nadu and Andhra Pradesh. But is it the correct statistics? The OP attendance
statistics is correct, but if you take up the private hospitals, Aravind is an exception. You see large private hospitals, they cater only to a small number of people. 500 cataract surgeries is the number of surgeries done by the biggest private eye hospital in Trivandrum.
No, I'm not talking about the surgeries. I'm just talking
even
about the
OPs, they may be seeing a large volume of patients.
1,000 OP a day.
Our OP is not decreasing, even if the other private hospitals are coming up and surrounding places. The main reason is the thing that I have already explained. The periphery, they don't have a regular OPD in the taluk hospitals. The people who go to the private hospitals are not the people who come to the government hospital. They are the poor category people.
I would
Yes,
just
sir.
like to make one observation. Unlike the normal perception, Kerala, the use of the public infrastructure is much more than the use of the private institutions. This is what I came to know recently. I went there. The utilization of the public hospitals is far more than the private hospitals, number one. Number two, the corporate sector is virtually non-existent. Number three, most of the insurance facilities are provided through the public institutions. Tomorrow you'll have Mr. Junaid Rahman, who has really transformed the Ernakulam and Kochi hospitals, a man who is heading a public institution. You will see him yourself.
Any questions to the people here? Kim, you wanted to add something?
One of the things in the vision centers that we have been successful in, not all of them, all the 40 are successful. Some are doing very well, and some of it totally comes down to the person who's running it and the people who are monitoring it. So there's a lot of accountability that has been put in. So that has been making it very successful. It is the same patients who are out there, but the people who are there have been able to make a difference. So I think if we focus on those resources, then the productivity will be much higher in these resources, in these centers.
The role of vision centers versus screening eye camps. Did you say in the future or? Okay. Okay. Okay, I'll take a shot at that. I mean, vision center is a fairly recent phenomena. Even though the government tried doing it through PMOAs, but then it didn't get structured in that manner. At least the way one very clear demonstration is that, see, the eye camps, one cannot do it very frequently. No, we cannot go there every week or every month, to a large number of places. So we have done a number of comparisons. not, I won't say studies, looking at an area where we have had vision centers, the number of people served in a year's time versus before the vision center came to the eye camps. So it's a world of a difference. Now, if vision center saw X number of patients, if an eye camp saw X number of patients in a year, vision center attendance would have been about 5 times, 6 times more than that. Okay. That is number one. Number two, the vision centers, at least the way we are running it, we have kind of made them with almost 100% cost recovery. Capital we have to put in, but then in terms of they pay 20 rupees, they pay for the glasses, some margin there, we're able to kind of break even. So which means that these things don't cost money to you. And we've also found a very high level of compliance to referrals. That is, amongst those referred for cataract surgery or for diabetic retinopathy and all that, a very high level of compliance. So we're seeing a lot of positives even as things are today. But looking into the future, I think our biggest challenges will be in things like diabetic retinopathy, glaucoma, and all those things, partly in diagnosis, but mostly in the compliance. Because you will recognize that glaucoma, you need to monitor them every year. I don't know if any of you are monitoring the compliance. In here, we monitor very closely. And we know that if you take a glaucoma patient diagnosed, say, 4 years back, his 5th year follow-up rate is only around 15 to 18%. That means 100 patients diagnosed 5 years back who come for follow-up 5 years later is only about 15 odd percent. And that is when they're at a higher risk of becoming blind. Same with DR also. So all this, I think, can be better addressed when you have a vision center. So today, one of our staff recently compiled for one vision center names of 1,000 diabetics. So they're all living within 4 or 5 kilometers of the vision center. So we feel that we can evolve some mechanism to make sure that they're seen at least once a year. So looking ahead, I think vision centers, will hold the key for number of things, for universal coverage, universal access, very eluding concept, but I think with vision center we can do that. And then supporting the tertiary care. I think they're going to be to me, that's going to be the foundation for doing it. Yes, sir. Venkateshwar Rao.
20,000 vision centers for the entire country.
Correct.
To cover the entire population. So I'd like to know the methodology of achieving that figure, taking into account the slow pace of progress that is already probably got the current point of time. The second part of the question is, now as we develop these vision centers, what is the model of integration into the regular primary health care? So whether this runs as a parallel system, or probably there are any plans in the government of India to integrate with the community health centers, which are there at 1 lakh population. So if there is a referral mechanism built up for 2 vision centers with the community health center, have an ophthalmologist at the community health center, probably that will act as a secondary care center rather than this. So the linkages probably will have to be explained.
So this is something I would actually appeal to the government to take it on a kind of a mission mode. Yeah.
No, you said that the vision centers do not stand apart. In the government sector, they are being established at the PHCs. So it is part of the public health mechanism. It's not a standalone thing. In fact, there have been some requests from some of the states, I think during the PIPs, whether they could set it apart anywhere else other than the PHC. So that is something that wherever it is being established, I think the 11th plan around 3,000 odd were supported by the government, and they are all in the PHCs.
So the government, I think, budgeted in the 11th for 6,000. I think probably 3,000 is what was achieved. I think. There. Okay. Yeah. Yeah.
Data that has been compiled has been in the last
3 years and culled out from the reviews. So basically there was a target of at least establishing, Rashekar, correct me, 3,000 it was, 3,000. So I think our latest, the last review, I think it was some to 2798 was the figure, I think. We might have missed out, but because we were taking figures mostly from the last 3 years. Maybe it's gone, you know, because in the eye banks, I find we have crossed the figures, you know, which we should have should have established.
Okay.
So those are there.
No. In fact, in the government of India, we have planned for street lamps at the lower end cost. So that would cost around 25,000-30,000 in the 2007 and 8.
Ma'am, suggestions for constructive synergy between the Department of Medical Education and Research, which handles the RIOs, and Department of Health and Family Welfare, of which the representative is the SPO, to bring about a common platform to take the program forward, because at times there are, at the administrative level, people don't see eye to eye. So how can you know, on a policy basis, how can we ensure this kind of common synergy to move forward?
No, I think that this is not not only in blindness. I think this has come up, but I think in the other sector that I deal, mental health. I mean, there the issues are quite this thing, because you have all the mental hospitals, everything in this thing, and the other. I mean, the DMHP is run by the state government, and all the mental hospitals and the medical institutions are all in the medical education. Very few secretaries or commissioners are the same. So this issue of coordination has been there. It has not come up so much for me, at least in the reviews in blindness. But like he said, I mean, I looked at the point. I think we need to forget you and I. He says we supply the reports. You have a leadership role. You must play that role. There is nothing, and if there is there, we need to take meetings at the secretary's level to ensure that coordination. So that it should not be a problem at all.
There is a suggestion, which will maybe eye-opener, not only for eye care, to provide the specialized primary health care at the CHC or primary health level by just changing the curriculum at medical education level, which is a very big change, but it will be very useful. So this will be that, but I had an idea that we have graduates in dentistry, BDS, so only in 4.5 years, while in medical college we have MBBS after 5.5 years. And at a primary health center level, we post 8 doctors, medical officers. They all are MBBS. They all are fighting with each other for post, so these MLC cases and others, and all programs. If we make a change, first year, 1 year, that is first professional, and then 1 year, second professional. And after that, we make graduates of medicine, graduates of ENT, graduates of ophthalmology. We have a period of 3 years left. And we post 8 medical officers. One is graduate of ophthalmology, one is graduate of ENT. So they will be doing their own work in primary health center level, providing specialized primary health care in every subject. And out of those who are graduates in ophthalmology, they can have MS and all that.
Very important.
As just BDS, we have MDS and later on like that.
Exactly. So this is a very important point that you are touching upon. Because what is happening is that after 5 years of MBBS, when after 5 years of MBBS, 5.5 years of MBBS, they join ophthalmology, they know nothing about ophthalmology, almost nil. So what is happening is that they are wasting their 8.5 years to do MS, and then of course, as I was speaking in the morning also, they have to come for fellowship in Aravind or somewhere else. So they take around 12 years to do some specialized work in ophthalmology. So what our suggestion is that this suggestion of Dr. Eyecare is very, very important, and government must take care of this.
Only for eyesight, all subjects, even gynae.
Subjects, exactly.
A lady doctor with MBBS degree cannot do anything, but a lady doctor with 5.5 years, with 3 years in gynae can do a lot in the village.
Almost like the BDS model you're saying, like
in
the BDS
our setup
model.
of PSC, what is happening is that optometrist becomes a medical officer there of ophthalmology. All patients are referred to him by MBBS doctors, or supposing some other specialist is there. So he becomes a doctor there, optometrist. So therefore this shortening of the period is very, very important, ma'am, and you should take care of that.
It's a major idea. I think we need to bring this session to a close because we still have a visit left. So I think just to summarize, we would request you to also write your ideas in the forms. We'll pick it up. Just to summarize the whole discussion of this session, so we would recognize that ophthalmology started as a secondary care discipline. Started with cataract surgery as the starting point. Then we went into tertiary care. So somehow we didn't have a structure for the primary care other than eye camps. So we talked about outreach and things like that. So today we have a couple of options, either vision center, which will be equivalent of primary eye care or the primary care service, however you do it, technology or without that. And then you have the outreach work or some kind of case referral at the community level. So I think we need to fill that void on a kind of a mission mode. If you really want to have universal coverage and then make sure that everybody who needs eye care is getting it. So I think we had some real good discussion, and then we will look forward to getting your own thoughts on this, which we'll compile. Thank you very much. I want to thank the panelists. Thank you.